Dr. Camarada and Dr. Bott are going to be doing our case vignette.
So we're going to, welcome back. We're going to role play here in just a minute. But I just want to say a couple more words about the controlled medicine agreement. There's actually no evidence that we're reducing specifically unintentional overdose with these, but it is recommended through many of the state medical boards and advise that you do this. I find it has great merit when I use it. It's a a very common way in the past when these were used. And they were really, like Dr. Ford just said, they were called contracts, pain contracts. They were the stick. They were like, if you break this, we're gonna cut the opioids out. And really, I see them as opportunities to do a lot more. You can share information with these. You can use it as an informed consent. It can be as a tool for shared decision making. And I think it's just an opportunity to foster a therapeutic relationship with the patient and talk about expectations. So I think the most important points that I try to use when I administer a controlled medicine agreement, and I administer it, I don't have medical assistants or my nurses do it, I do it myself. I think one of the most important messages I deliver is, I hear that you have pain, and I want to care for you with it, and I believe you. These medications, they may help, but they also potentially are harmful, even very dangerous. So that's another thing we want to get through. And all the decisions that we make regarding the controlled medicine agreement are through the lens of safety. That's really the big one, and that we want to treat this pain. So even if we are discontinuing opioids, it doesn't mean we want to give the message we're no longer going to treat the pain. So the scenario is, this is Mr. Begay, and he has chronic low back pain. He's never been on an opioid before, and he received a hydrocodone and acetaminophen from his wife, who obtained it elsewhere, and it helped his back pain, and he wants to start using them. We have done all the pre-work before this, risk assessment. We've done an exam, taken a very thorough history. At this point, we've come to the conclusion he might be a candidate for a trial of chronic opioids for non-cancer pain. Other things in his past, though, that are some we need to negotiate some things, because he does drink some wine at night. And he's got some other things that we're worried about. So, and these will come out as we talk a little bit. And I want you to be thinking about these. What would you do with this patient when it came to these points? Okay, so hello, Mr. Begay.
Hi, how are you?
And your understanding of why you're here today, please?
Yeah, we're gonna talk about the pain and what I can take for it and just feel better. Thanks for seeing me.
Of course, of course. So, of course, we've talked all about your pain before. We're going to talk about the medicine that you were inquiring about, the hydrocodone with acetaminophen. Long name, but it'll be on the bottle there. And what we're doing is actually, I have this paper in front of me called a controlled medicine agreement, and we're both going to sign it. And I just want to point out the title, controlled. So these medicines are controlled. And the reasons they're controlled is, of course, we want them to help you with your pain, but in some patients and in some circumstances, they can cause harm. In some patients, they've actually caused death. So we have to be very careful with this. We don't want anything to happen to you. We want good things to come from this.
That's a good goal, Doc.
So that's why we go through this whole thing. All right? So I'm going to...
So then is that going to go in some government file? Or, I mean, is that everyone's gonna know I'm on a controlled medicine? What does that mean?
Well, it's a very good question. So this will go in your personal file we keep here in the office, but we don't share that with agencies.
Okay.
But people who have access to your file, we have strict laws on and policy on who can look at that.
All right.
Okay.
Okay.
All right. So. I'm just going to read the most important parts of this, and then at the end we'll go through more. But really the most important says that your clinician has prescribed controlled medicines for you. These medicines can help you. They can also hurt, and I said rarely, but kill you. This agreement explains how to use them, and this agreement lists some of the dangers of these medications. The names of the medicines, we'll put them down. I use these for pain, and I want to help me with, you told me before you wanted to do a little bit more dancing.
Yeah, we used to go dancing all the time, my wife and I, and we haven't done it now in close to 3 years at this point.
And you did?
And, you know, and now I've got a couple of grandkids, and I want to be able to play with them. You know, they're in Little League, and I want to play with them, and I can't do that either. And that's... Yeah.
Yes, and you explained in our previous discussion how important these things were to you, like who you are. So we want to work on those things. Can I tell you that with these medications, we're going to make you like, you know, stealing third to home, you know, and I don't know about that. We're going to see. It's a trial. But I do believe that you're the type of person we want to try to, you know, work with these and see where we get. Okay? I'm gonna work together with you. So these say using these medicines, again, controlled medicine, they bring up another line. These medicines can be dangerous. If I take controlled medicines with alcohol or certain other medicines, I could get sick or die. Now, we talked earlier about, tell me again about you have wine at night? So tell me about that.
Yeah, I mean, I don't drink. I mean, I don't get drunk or
Right.
drink hard liquor or spirits or anything.
Yeah. But you said you had 2 or 3 glasses of wine. It was a ritual with your wife.
My wife and I, but just with dinner, we have wine just about every night. You know, just a couple of glasses. We kind of just share a bottle, open it up, and have a couple just with dinner, and then that's it. We don't, you know, that's it. We don't go and party or get drunk or nothing.
Sure. No, I get that.
Yeah.
The problem is that these medicines, if they combine with alcohol, they can reduce your breathing and people can stop breathing. So I'm sorry to tell you this, but I want you to stop drinking alcohol if we're going to use these pain pills.
But even, like I said, I don't really drink much. I mean, I see people around, you know, all the time who are drinking, and I'm nothing like that. I just have some wine with my wife, and when I took that one pill for my wife, I was okay. Nothing happened.
I get it, and what we're doing is trying to be as safe as possible. And when we look at all our medical information, the recommendation is that you not drink when you use these
at all.
pills.
Like not even a glass of wine. Like what about like half a glass of wine or a glass of wine at night?
If you're taking the medicine throughout the day, I wouldn't do that. If you don't take it over 24 hours, it's usually out of your system. And so these medicines we talk about using only if really needed. There might be times that you can do that, but I would really say not in the same day.
Okay.
It's a tough one. I'm sorry.
Yeah, it's just something we do, you know, together.
And I get it. And again, we just safety first, safety second, safety third. That's the way we go about this. The other thing is you could get a little sleepy when you start these pills. If you took one, you didn't say, but if people take them again and again, sometimes they get sleepy. So when we start out these pills, till I kind of let you know, I don't want you actually driving. I don't want you being sleepy, falling asleep, harming yourself or others. Same thing about being around, you know, dangerous equipment, chainsaws, heavy equipment. Can you do that?
Yeah, I can do that. I mean, for a little while. I mean,
Usually it's a week or 2, unless we go up on the dose.
Okay.
So it's not forever.
I can do that.
Not forever. Okay.
I mean, it's gonna help me, and that one pill, like I said, helped a lot. So if it's gonna help me, I can work with it.
That's great. Again, we talked about the breathing, how it can lower your breathing, especially when mixed with. But that breathing issue means you're going to take them only the way I prescribe them. If I say one pill, only one pill. Even if it doesn't work, we're going to talk about it. Even if it doesn't last long enough, we're going to talk about it. You don't take 1.5 or 2. You don't take it sooner than prescribed. Okay, and that gets away from that trouble breathing. You could get allergies like any medication, and we'll have some further information later about what those might look like.
Right.
But some people get some side effects, like they get sick to their stomach or they throw up. That will usually go away. Some people get constipated. I'm going to give you some medicine to try to make sure that doesn't happen.
All right.
So, but if you have side effects, you need to contact and let me know. And usually most of them will go away. All right. In some people, and it's not common, but in some people, they can actually get dependent on these medicines.
What does that mean?
That means they can need to take them to the point where they could actually become an addict. And so, yeah, we don't want that to happen. So we will be monitoring the use of the medications. You talked about your past. You were forthcoming, and I really appreciate it. You did talk about your past when we talked about drug use, and you said, well, back in high school I used some stuff, you know.
Yeah,
So,
back then, yeah.
yeah, so I just want to let you know that we're going to be doing some things to monitor, because we do know from...
Because of that?
Well, what we know is from
like 30
other...
years ago now.
I know, it's weird, but other patients that used those like speed or things in the past, even 30 years ago, they're at a slightly increased risk of misusing these medicines.
But I got clean. I haven't used it, you know, and like I said, close to 30 years at this point. I haven't even touched that stuff.
And you're awesome. You really are. I admire you.
My grandfather, I don't mess around with it.
But for safety reasons, we're just going to watch you a little bit as we go along. And I'm thinking, from knowing you, that that's not going to be an issue. But we do have to monitor, including we have to do these urine tests. We're going to look in the urine for... We have to look for illegal substances.
I'm not an addict.
No, I know, and that's what everybody says. What do you think, I'm an addict? You know, I don't think you're an addict, but because of people who have misused these, not you, but people that have misused these, there are regulations that we have. We have to check this on everybody. If I took these medicines, if you were my doctor and you gave me these medicines, you'd be checking my
So you do it to everybody then?
Everybody. Policy.
All right.
Okay?
So it's not just me, or because...
Not just you.
Because of that?
No, not at all. It's because of our medical knowledge we have and our experience. So the things that you're going to do is you're going to follow the treatment plan. And mainly that's, like if I say take them only one way, don't take them different. We might work with physical therapy, some other things. You're going to really do your best to try to do these, okay? If you... You'll follow there's some rules in the clinic about when you can pick these up. We can't do it all the time. You just want to know those rules, and we'll work the best to work so you can have them on time. If I'm not here, I'll let one of my colleagues know to prescribe them. If you miss your appointment, we want you to make a new one. The way that we follow these is we see you, we talk about it, we see if we need to go up or down, okay? The biggest thing is kids come into houses, they get these to people's homes, and they find them and they take them. Some kids are looking for these. Younger kids, teenagers, and they overdose and die from it.
I see it all the time.
You've seen it on the news, right?
I see it, yeah, everywhere.
So I want you to get a locked box.
All right.
Got to get a locked box and lock them up.
Well, we already have one because of my wife. So
perfect, perfect. If somebody steals your prescription somewhere, they take your pills, report that to the police. Right. It's really important, okay? The things you won't do, and we already went over this, and I don't expect this, but we say this to everybody. I will not take illegal drugs. We already talked about that. You already talked about I will not drink alcohol. Sorry. I will not get controlled medicines from other doctors except in emergencies. So I don't want you going to anybody else out of this office and getting these, because again, they may not know you're taking these. They add them up. They add up to accidentally cause breathing problems. So accidental overdose. So if you go to the emergency department, you make sure you tell them, hey, Dr. Camerata is giving me these, this is my prescription, and they may go, oh, you can use this, or oh, thank you for letting us know, you know, we're not going to get. So what if they give you other medication, you need to let me know about that. That's really
what if
important.
You're out and you're on vacation?
Right. Part of my job is to make sure that your prescriptions are there, that I see you on a regular basis, and if I'm not there, one of my partners, I talk to my partners about this. You're absolutely right. So I'm going to do for you, I'm going to make a treatment plan, okay, that we talked about a little bit. And we may increase the medicine. If they're not working, we may even decrease or stop them, or if there seems like there might be harm coming from them. But this is a trial. You and I are going to talk, and we're going to follow this along. This isn't the only thing we treat the pain, though, with. You've done all those other things in the past, and we're going to talk about doing more of that. This is just one tool that helps. And then we talked about the urine. We have to check that every so often. I think that we'll get less and less checking those urines. Okay? Right. Do you have any questions now of me?
I mean, is it going to help me? Is it?
I hope so. I can't answer that. Everybody's different. Some things respond, some don't. But this is something we're going to be talking about, and that's our hope. But we just don't know. This is a trial. If it's not working, we're not going to keep doing it. We would stop it and maybe even get to a pain expert. I might send you to one of my colleagues. Okay?
All right. Well, thank you, Doc, for taking the time to talk to me today.
All right. Thank you very much.
Thank you.
Okay. So that might be different than you have used before. It might be different than you've seen them used before. I think really the most important part is I see this as an opportunity to establish a relationship with the patient, and a therapeutic relationship. You'll get, when you do this, taking a careful psychosocial history, you'll find out a lot about your patients. In this case, this is a young guy that grew up in a very challenging situation at home, and he just wanted to feel better. He started using some, amphetamines, and ended up actually selling a little bit. There were some financial issues too, that he needed money, and he ended up going to jail. And he really learned his lesson. He's been clean as could be since then. And so, you get the backstory, you get the narrative of patients when you do this type of work, working with patients, and that allows us to see a different perspective of our patients. So I think that's really important, that you go through these, you take the time to go through these detailed history and find out. And it gives you there was a quote by, I'm trying to remember, a philosopher who said, to know one is to forgive one. And it can help us suspend judgment with patients that have misused these medications in the past, and why they might potentially be using them. In our experience, people just want to feel better. They have pain. And again, the message is, I hear you have pain. I believe you. But the other part of that is, we may not be using opioid medications for all of your pain. We really want to explore that. So that's the main messages. I think we have about a minute left. I don't know.
Let me jump in, because there was lots of discussion around how much time this took, and that's just not realistic. Yeah. So, one of the things I will say is that I recognize that. I mean, I've worked in our facilities, and I know our primary care providers in particular are really crunched for time. A couple of things came up in the chat. I just want to point out, if you do have other things that support staff, colleagues can do, the nurses and medical assistants, have them do that. They can take some of this information. I know Dr. Camarada feels really strongly about doing this part himself. If you have that opportunity, I think that's great. The other thing I will point out is that, this is mandatory training for all primary care providers. So, your supervisor, whomever that is, or if you're a supervisor, they've gotten this training, and they've heard these same things, that these kinds of patients will take more time, and that's just sort of the bottom line. And so how your clinic deals with that, I know someone in the chat put in that, they have certain days that are their pain clinics, and that's how they do it. Just like that you would have a diabetic clinic or a, different other clinics. I think that, I think the other piece that you will see these patients, you can't screen them out and say, I'm not going to see them, because you never know when they walk in your door. Oh yeah, I've had diabetes. No, by the way, my leg's really been bothering me for the past 2 months, and now can you help with that too? So I don't think there's a way to
I would add to that a chronic pain patient is a complex patient. These patients, and it has tremendous impact on their lives. And I see my role as relieving suffering and trying to prevent it. And they suffer greatly for these things. So I see them as being very complex patients. Honestly, I usually will administer the controlled medicine agreement in a whole separate visit. Take the time to go through that. Usually you can find 15 minutes, but I think it's important enough you schedule the patient for that. I know that people have limitations, but I think it's that important, and that's the way I approach it.
And as Dr. Taylor sets up for her presentation, the one other thing I would add is that it's a lot of work up front, absolutely, but it may actually save time down the line as you work with these very challenging patients, because you really clarified the expectations and the goals for both the patient and also for the provider. So it may actually, in the long run, wind up saving some time, at least in my experience. Is the last everyone who is logged on, kind of try to bring a lot of the things we've talked about together and really talk about regulations pertaining to pain treatment. First of all, thank you to Dr. Commercy, from whom we just heard, who initially put this presentation together. One caveat is that this is probably the one presentation that changes a lot. even from month to month or certainly year to year, right? Because new regulations, new best practices are always coming into play. So with that, let's begin. Some of the objectives include explain to a colleague the classification system pertaining to controlled medications, describe the prescribing guidelines as they relate to controlled medications, and describe best practices for treatment of chronic pain with opiate analgesics. And I think that's really the meat of this presentation that I want to do focus the most on. And then if we have time, we can go into interpreting a PDMP, the Board of Pharmacy Prescription Monitoring Program report. So as we talk about this, I think it's very important to approach this issue with the need for balance. As Dr. Katzman laid out right at the beginning of the day, there's this dual epidemics of chronic pain and of opiate misuse and overdose. And we really need to be cognizant of that and be able to treat both of these appropriately and safely. In fact, White House has called opioid abuse an epidemic and a growing national crisis. It's been, of course, all over the news, all over the media, and for good reason. On the other hand, as Dr. Katzman pointed out, 100 million US adults do have chronic pain and medications need to be accessible to them. As Margaret Hamburg pointed out, we have an important balancing act of trying to ensure that safe and effective drugs are available for patients who have real pain and need medical care. And at the same time, as we've been discussing all day, we need to be able to do so safely. So the fact is that all of us receive mixed messages about the use of narcotics and sedative drugs, right? It's a case of, damned if you do. This is a Newsweek headline talking about sort of the dangers of prescription opioids. And on the other hand, we've got this headline of doctor being found guilty of elder abuse for under-treating pain. So it's a fine balancing act between under-treating pain. We want to be able to treat pain, but at the same time, we don't want to be contributing to sort of the epidemic of opioid misuse. The other fact is that we are using more opiates and sedatives than ever before. As the next slide points out, as the rates of opioid prescription have risen pretty dramatically and exponentially over the last couple of decades, so have rates of overdoses attributed to opioid analgesics. Both have gone up. And in fact, I believe it was in 2010 or 2012 where a paper came out showing that Americans make up 5% of the world's population, but consume 80% of the world's opioid analgesics. So certainly there is this, a lot of prescribing going on, and there has been this growing overdose epidemic. The many issues came to fore that have illustrated this potential conflict about treating chronic pain on one hand, and on the other hand, preventing and not contributing to opioid abuse. And one classic one was the hydrocodone containing combination product rescheduling that happened back in October 2014, right? And really what I would point out that, one of the things that I guess I've gleaned over just following the news and what's happening nationally is that when you try to detach these two issues, it becomes extremely complex and it becomes very easy to ignore one or the other. So we really have to approach these two in tandem as sort of co-occurring illnesses or co-occurring issues. We as providers, all of us, physicians, nurse practitioners, PAs, clinician pharmacists, and other healthcare providers all have an obligation to understand the indications for these medications, for opioid medications, which we've talked about so far during the course of the day, the potential problems that can ensue from the use of these medications, which we've also kind of addressed and talked about, and the third thing, which is really the focus of this topic over the next 25 minutes or so, which is the regulatory guidelines that inform our prescribing of these medications. Moving forward, so we'll start with the case vignette, and again, thank you, Dr. Commerce, if you're listening somewhere. I'm not sure if he's here or not for coming up with these. CG is a 44-year-old male with a history of chronic low back pain. You treat him with oxycodone 5 milligrams 3 times a day. You have monitored him for aberrant behaviors, you perform regular urine drug monitoring, and have queried the PMP, and all is in order. He requests that you phone his oxycodone into his pharmacy. You attempt to do so, but are told by a very astute pharmacist that you cannot phone in C2s. So let's use that as a way to jump into a little discussion about scheduling of medications. What are controlled substances, and what special prescribing requirements do they have? So in our country, several attempts have been made to regulate narcotic drugs. The first major attempt was in 1909 during the US Opium Exclusion Act. What that essentially did was it actually banned opium dens in our West Coast cities, San Francisco, Seattle, Portland, etc. But really didn't have much impact beyond that. The second, and probably a bigger, more pertinent legislation was the Harrison Narcotic Act of 1914. Actually went up to the US Supreme Court, who ruled, I believe in 1919, that physicians could no longer prescribe opiates out of their office to treat addictions. And I think that's the legacy of methadone clinics, where physicians can prescribe methadone out of her office for treatment of pain, but not for treatment of opiate addiction. And that's why we have methadone clinics. That's really what it did. And that's why buprenorphine, when it came out, was really created as a Schedule III medication and took an act of Congress, the Drug Abuse Treatment Act, to be able to be prescribed from a physician's office for treatment of addictions. And the third act was the Controlled Substances Act of 1970. What did the Controlled Substances Act do? Well, first of all, it's a means of categorizing dangerous drugs according to, and again, it's another balance, medical utility on one hand and abuse liability on the other hand. And those are the two factors that are evaluated before a scheduled class is assigned to a medication or a drug. It's a means of regulating manufacturing, distribution, and prescription of these drugs. And it also created the Drug Enforcement Agency, the DEA. So what are some schedules? So Schedule I drugs include things like heroin, LSD, and cannabis. And I put cannabis in parentheses because it's a really unique case, right? Where it remains on Schedule I federally, which means that it has a very high abuse potential and no medical utility. On the other hand, almost half the states in the country at this point have medical cannabis laws. And several states at this point have recreational marijuana. So I was actually listening to a recent interview with Margaret Hamburg maybe 2 months ago, 3 months ago, because she's, I believe, leaving her FDA position. And the reporter asked her, what's the one thing you did not anticipate when you when you stepped up to the position? And her answer was how quickly the climate and laws are changing and have changed around cannabis. And she's like, we can't predict what's going to be the case 2 years, 3 years from now. So that's something that's in flux. However, according to the federal laws, and of course, as Dr. Ford pointed out earlier, IHS as a federal agency very much will continue to treat cannabis as a Schedule I substance. They cannot be prescribed. They have a very high abuse potential and no medical utility. So the states that have medical cannabis laws sort of get around that, right? Because, for example, I as a physician cannot prescribe cannabis, right? Because it's a Schedule I substance. So in the state of New Mexico, if a patient has a qualifying condition, I write a letter stating that the patient has this condition, other things have been tried, they have not worked, and that I recommend cannabis, which then goes to the State Department of Health, who then approves or rejects the application and gives the medical cannabis card. So that's sort of a workaround that states have created around this. Schedule II substances. Morphine, cocaine is a Schedule II, right? It is, many of you ER physicians or ENTs might have used it in a medical setting. And hydrocodone combination medications, which used to be Schedule III until about 2 years ago, and were increased to Schedule II in light of their abuse potential. So again, according to the Controlled Substances Act, these have a very high abuse potential, but are also medically useful, so both are high. Can be prescribed for 1 month, no refills, no phone-ins. So let's talk about that in a little more detail. Emergencies, right? So this is a question that comes up. What happens in the case of an emergency? So say there's a big blizzard, a patient really needs this medication, but there is a blizzard, as there was up in Montana just a week or so ago, right? And the patient can't get to the clinic. Well, according to federal and IHS guidelines, in emergencies, a physician or a provider may call in a limited supply and then provide a written and signed script within 7 days. So that's sort of a workaround that is allowed legally. Other Schedule II consideration, again, per federal and IHS guidelines, provider does not need to see the patient monthly, right? You don't, because many of you might be saying this is a lot, right? I'm busy, I have a lot of patients, and I can't really see this patient monthly. Well, if a patient is very stable, if you do believe that the risk of diversion is low, risk of misuse is low, and the potential to help the patient with this medication is quite high, then again, legally, you can give up to a 90-day supply. You could do 3 30-day scripts or 6 15-day scripts or whatever, however you do it, but you can do up to 90-day supply. Right now, I'll tell you, I have just one patient in whom I'm doing it. It's an elderly male who has done very well, has not used any substances, is functioning quite well. The medication has helped him, and it's a Schedule 2 medication, and I give him 3 30-day scripts, each one dated for the appropriate date. But that's the only patient I have, because you really should be weighing the risks and benefits of doing that, right? So, and each script cannot exceed 30 days. Some conditions that should be met. Number one, each separate script should be for legitimate medical reason. And if you have an EHR, it's going to be documented in your note, which is important. Appropriate date on each script, and document consideration of risk versus benefit in your note. Somewhere that I do believe that the risk of diversion is low, the patient has not displayed any aberrant behaviors, the patient is functioning well, he's compliant with all the requirements, etc. However, always verify state laws, because state laws sometimes can be more stringent than federal guidelines. So for all of you, I would urge you before doing this just to verify your state laws, or ask your pharmacist, right? Pharmacists are, I found, always a great source of information, and check in with them. Schedule 3, buprenorphine is the one medication that I use a lot, which is a Schedule 3 medication, right? Crucial for opioid replacement therapy. This can be prescribed for 1 month. You can refill it for 5 months. You can phone in. However, to be perfectly honest, I have 0 patients in whom I refill buprenorphine for 5 months. I think the most I do is a month with a refill. So use your clinical judgment. If it's a new prescription, you can only call in a 10-day supply. Schedule 4, many of our benzodiazepine medications fall under Schedule 4. Similar to Schedule 3, they can also be prescribed for 1 month. You can refill for 5 months. You can phone them in, but only for 10 days if it is a new prescription. And finally, our Schedule 5 medications include pregabalin in the context of pain management. Gabapentin is not federally scheduled, pregabalin is. Many of these medications used to be over the counter in some states. They can be prescribed for a month, and you can refill for up to 5 times. You can phone them in. Lot of stuff, new stuff, and I actually have a separate slide collection on the CARA Act that just got passed about 2 months ago, right? But I'm just illustrating that in 2014 there were 208 pain-related laws signed into around the U.S. So again, just goes to show that this is a slide set that's always going to be changing, and you should always be verifying your state laws. At this point, most states have issued best practices for management of patients with chronic pain. Most states have issued prescription monitoring programs, and as Dr. Katzman mentioned, for example, in the state of New Mexico now, if you're going to be prescribing opioids for any more than 4 days, the law states that you must check the PMP. IHS Pain Management website, which Dr. Ford talked about earlier, it's a great resource. And so things are changing fairly rapidly. In 2017 proposed federal budget, and actually we're just starting to take advantage of that, hopefully. The budget really provides for significant amount of monies for access to increasing MAT, to increasing services for prevention efforts, naloxone distribution, but then also for medication-assisted treatments. So I think that's been a real positive development within the last few months. Okay, so with that, let's move to case number 2. Your office nurse reports that a very serious man is at the front desk to talk to you. When told that you were busy with patients, the man produced a badge and indicated that he was from Santa Fe, which is the state capital here in New Mexico. You receive him in your private office, and he indicates that he's an investigator from the Board of Medicine. A pharmacist has filed a complaint with the board, alleging that you overprescribe Schedule 2 drugs. Worst nightmare, right, in a way. What would you like your records to reflect when this man reviews the charts of your chronic pain patients? And this is, I think, where I want to spend majority of the remaining time for the presentation. Boards of medicine across the country have developed guidelines which define safe prescribing practices and describe conditions that must be met by the prescribing physician in order to demonstrate that she is using these drugs appropriately and safely, as we've talked about. So, these are some best practices. So a proper treatment plan must be implemented for all patients who are receiving treatment for chronic pain. And the components of this proper treatment plan include First of all, a complete H&P, complete history and physical. And the history and physical really ought to include, if you're following best practices, the history and nature of pain, effect on functioning, as we've sort of brought up throughout the day. This is something that's critical for us to be mindful of and assess periodically, and really set objective functional goals with the patient. Past treatment regimens and their effects, including history of and potential for substance abuse, right? So that's where my earlier talk comes in. Did you think about the personal risk factors? Did you do a risk assessment tool maybe? And did you come up with a plan to monitor for aberrant behaviors? Detailed psychological history, especially relating to depression, suicide, etc., and indications for opioid therapy. Now, many of you might be freaking out. That's a lot, right? But a couple of things. First of all, not all of this has to get done in that first session. You start the process. And as you get to know the patient, as you establish rapport, you start filling in the blanks. Also, feel free to use your colleagues. For example, your behavioral health colleagues. I know many of you are online who are behavioral health folks, and you guys are the experts really in doing some of these psychosocial assessments, which are critical, as we've talked about, to comprehensive care of a chronic pain patient. So utilize them, right? Utilize their expertise to provide this state-of-the-art care. Some of the rules: be familiar with the use of screening tools, as we've talked about. And again, I recommend getting one done, right? I suggested the SOAP bar. Dr. Camarada uses the ORT. You know, whatever you use, have it done, discuss it with the patient, and sort of scan it right into the EHR. And then periodically, when you do a treatment plan review, I think it's appropriately to do the continuing opioid misuse measure, and again, document it right into the chart. So that way, if there is ever an audit, they know it's right there and they can just quickly look it up. Use a variety of treatment modalities, right? I think all of us here would agree that opioids, really for chronic non-cancerous pain, shouldn't be the first treatment that you think about. And I think that's very important to document. Did you think about other things? Did you think about non-opioid medications? Did you think about non-pharmacological or traditional interventions? Some of them may not be available, and that's okay, as long as you document that, yeah, I considered it. Unfortunately, this is not something that can be available to the patient at this time. I think that's perfect. What the auditors want to see is that you didn't just lock right into opioids without looking at the broader picture, and use an integrative approach to pain as much as possible. Document an individualized treatment plan, right? So if you looked at the individual risk factors for the patient, if you come up with an individual functional goal for the patient or functional goals for the patient, if you've done a risk assessment tool, that's already leading to that individualized treatment plan, right? Because all of that is what's going to help you come up with what medications you'll use, how intensely or frequently you'll monitor that patient. So all of that is already leading towards this. So this should not be a whole lot of extra work really for you. And a line or two about when you're going to do referrals or consultations may be helpful. Next, discuss and document the risks and benefits of using controlled substances, including common and serious side effects, pregnancy, risk of combination with alcohol or drugs, driving dependence or addiction. I think this pairs very nicely with the controlled substances agreement. And if you have a standard controlled substances agreement in place, and has that been made available to the group, Dr. Four?
Yes.
Wonderful. So as long as that's your standard of care, it's what you do with all patients following universal precautions, the auditor should not give you a hard time about it, because that's sort of your standard practice. And traditionally, they have accepted that when they do an audit, right? So I think all of this is covered very nicely in that. Maintain complete and accurate records of care provider, drugs prescribed. Of course, for many of you, and I suspect that's most of you using EHR, this is fairly easy, because just the medications list is going to keep track of the medications when it was prescribed, the quantity prescribed, and your corresponding note would list the indication and just where the patient is functionally. So that actually should be fairly straightforward, especially for those using electronic health records. Next, the agreements are important. We've talked a lot about the agreements during the course of today so far. So moving forward, next, patients must be monitored, and a periodic review of treatment plan must occur at least every 6 months is something we recommend. So at every 6 months, go back, and I think that's a great time to administer the continuing opioid misuse measure. I'll just throw that in there. When you do this review, the things you're looking at are goals and objectives being met, the goals you had set together with the patient. How are they progressing towards it? Is there a change in the patient status? Maybe they're improving, or maybe they're functionally worsening. Is the patient complying with the treatment plan? These are the things you want to document, because these are the things that are going to ultimately help you decide whether you need to change the course of treatment you're providing. Right? So that really should occur every 6 months. Obtain consultation. When additional assistance is needed for patient evaluation and treatment, reach out to one of us. Certainly, reach out to one of us. You can do an online echo, and is that right that can be documented in the patient's chart if they have done an echo consultation, that the consultation was obtained? So. That's my understanding as well, that you can document that the consultation was obtained, and I think that's another way to solidify your care plan in your chart. Moving forward, next, pain management for patients with substance abuse disorders must include that formal agreement, appropriate consultation, drug screening, and reevaluation at least every 6 months. I think these are the folks who are high risk, and these are the folks who really should be monitored relatively intensely and frequently. Interestingly, there was a study about 5 years ago. What the authors did was they took their chronic pain patients, they classified them as high risk versus low risk. Patients who are going to be on opiates for chronic pain. And for the high risk patients, they actually provided a relatively low cost and low resource utilizing intervention, which was that they met with these patients once a month. And what happened during these visits was they provided opioid education, they did a urine drug screen, they did a pill count, and they did a little bit of motivational interviewing to talk to the patient and hopefully address any ambivalence they may have about the use of these substances. And they did this just once a month for 6 months. And at the end of the study, there were actually no difference in the rates of aberrant use between the high risk and low risk patients. So just doing that, which was literally about a 15-minute intervention, really brought the risk of the high risk patients down to that of the low risk patients, right? So just provide that extra step, that extra intervention to be able to treat these patients safely and effectively. So if you comply with these things, if you do some of these best practices, you really will be complying with your state medical board guidelines, which you should certainly verify for each state, and Controlled Substances Act and IHS guidelines. Now, a slide on its own, because this is a question that comes up frequently. Clinicians are not obligated to fill opiate prescriptions if they feel that the patient is using drugs in a medically inappropriate fashion, or if these medications are not indicated. You are legally protected there as long as you have documented why it is that you're not prescribing these medications. So I did want to point that out. Next, prescription monitoring program. We strongly recommend, and at this point most states actually require, that any practitioner with a DEA will register with the PMP. When we made this presentation, it used to be 10 days checking the PMP for anyone you'd be prescribing opioids for 10 days or more. But many states are now becoming more stringent. For example, New Mexico, it's 4 days at this point to check the PMP. So if you do all of these things, you really will be complying with the guidelines and the laws. And when the board does evaluate a physician and the quality of care, they're really looking at the following factor: appropriate diagnosis and evaluation, appropriate indication for treatment, document change or persistence of condition requiring opiates, that's that periodic review, regular follow-up evaluation, and the validity of prescribing is based upon the quality of care and not the quantity of opioids prescribed. And the goal ultimately is to effectively and safely control pain, taking into consideration biopsychosocial and work considerations. Summary, we've talked about the Controlled Substances Act and the regulations pertaining to the scheduled drugs and best practice guidelines and requirements in regard to the use of opioids and the treatment of patients with non-cancer pain. And I believe at this point I have just a few more slides on CARA, which just recently got passed. And I think it has some significant implications for medication-assisted treatment for our patients who do present with opioid use disorders, which of course are associated with a variety of adverse outcomes. So if we can...
Just one thing, and I want to point out, Jeremy, thank you for bringing this up. We sometimes forget to mention this, that PDMP does not cover VA.
That is true.
And so if you're treating a veteran population, it also does not cover methadone.
That is right. As of now, it does not cover VA or methadone maintenance programs. And there is a lot of debate actually about whether, right, because for example, at my clinic, I have patients on methadone maintenance treatment, and if they go to see Dr. Katzman for primary care, and if the patient doesn't disclose, Dr. Katzman would have no way of knowing that the patient is on methadone maintenance, which can, as you can imagine, be quite dangerous. So I really, when I talk to the methadone maintenance programs, and when I educate them, I really always say that it's the responsibility of the methadone maintenance program to be checking the PMP. And if you notice that the patient is receiving other opioids, to address it and contact that provider. But great point. Thank you. So, do I just hit forward or?
It was a separate. Yeah, try to hit me.
No, I think it's a separate set. But that's okay. That's okay. I think we have 2 minutes left. If we can pull it up, that's great. But what I wanted to bring up about CARA, which just got passed, I believe, about 2 months ago, if that, at this point. And CARA really did a couple of things. Most importantly, CARA has now expanded. So until the CARA was passed, only MDs or DOs were able to prescribe buprenorphine for treatment of opiate addictions. But with CARA, now that's expanded to nurse practitioners and physician assistants. They do need to undergo 22 hours of training, including the 8 hours of standard buprenorphine training, plus 14 additional hours of training. And at that point, they actually will be able to prescribe buprenorphine. SAMHSA is currently in works of creating a standardized curriculum. They've kind of gone back and forth about when it will be ready. The most recent I heard is that it may be as early as February. So that's wonderful because that's really going to increase access. Unfortunately, at this point, our pharmacist clinicians are not included under CARA. And actually, many of us are advocating to say that really that's another group that really ought to be included to be eligible to prescribe buprenorphine under CARA. The other thing CARA has done is really to expand physician limit from 100 patients with buprenorphine to 275 patients with buprenorphine. In my honest opinion, that's actually likely to have a lot less impact because the average physician with buprenorphine waiver treats about 25 or 30 patients, right? So they're far from 100. So going up to 275 for many physicians is not going to make a huge impact, but it's really that provision to allow nurse practitioners and physician assistants to prescribe buprenorphine, I think is a fantastic thing as we talk about opiate addiction and chronic pain, just something to keep in mind that I wanted to highlight. And I'll end it with that, with 30 seconds remaining. Right. And I believe we have another case vignette coming up.
We do.